Welcome everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, you may use that chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff, our co-host, and guest speaker will see your questions. Please do not share any personal medical questions or information in the chat box. If you have a personal medical question, please ask your doctor. So next, I would like to turn it over to Brianna Beckfold. She is the project manager and editor for Mass General Hospital for Children, and she will introduce you all to today's guest speaker.
Thanks, Amy. So good afternoon. I hope you're all doing well, and thanks for coming to this virtual session of the MGHfC Parenting Series, where experts share their knowledge with patients, family, and staff on various pediatric health topics. This year, we're co-hosting the series with the Blum Patient and Family Learning Center at Mass General. As Amy said, my name is Brianna Beckfold, and I'm a project manager and editor at Mass General Hospital for Children, which is the pediatric branch of Mass General. And today for our speaker, we have Dr. Evangeline Galvez to share tips on how parents and families can ease the transition when their children move from pediatric to adult care. So before we begin, I'd like to briefly introduce our speaker. Dr. Galvez is a pediatrician in pediatric primary care here at MGHfC and at the Revere Healthcare Center. She's the director of the Internal Medicine Pediatrics Program in Pediatric Residency here at MGHfC, and she earned her medical degree from the Loyola University Stritch School of Medicine and completed her residency at Rush University Medical Center in Chicago. So as Dr. Galvez presents, we'll take questions from the audience in the chat box, and from here, I'll hand it off to our speaker.
Thank you so much. Thanks so much for this opportunity and talking about this subject. I'm going to have some slides just to keep things on track. Give me 1 second to get this started. All right. Does that seem okay? You guys can see that all right? Perfect. Well, welcome so much. We're going to talk today a little bit about pediatric transition to adult care. I'm going to talk a little bit about kind of my background for a hot second. I am an internal medicine and pediatrician. So I have double boarded. So I did actually 2 combined residencies, one in internal medicine and pediatrics. It's an interesting training program. There's about 395 slots throughout the country each year. I run the residency program here at Mass General, and we rotate through both the adult side and the pediatric side. I am a primary care doctor, so I get to see kids and adults from birth to, my oldest now is currently 96, my youngest is just born. And I take care of actually like 4 generations of families. I'm also a parent. So I'm also a parent to a neurotypical 7 going on 8-year-old, but I'm also a parent. I had a very complex medically fragile little guy so I absolutely understand the idea of navigating the healthcare system from both lenses with multiple specialists with a rare disorder, not to mention also a survivor of navigating a parent with end-stage cancer needs. So I have a really unique lens about the kind of the space of the navigating the medical system from both ends. So conflicts of interest, I have no financial relationships or commercial entities. I am a primary care physician in an underserved area. So I'm fueled by passion of helping others. So today we're going to talk a little bit of the difference between transfer and transitions, differences between pediatric and adult care to kind of classify how the transitions is a little bit difficult and can kind of pop up in conversation or pop up in surprising us as our child kind of grows throughout the system. Suggested timeline for transitions, factors to consider for each young adult, and some resources. We'll also go into a little bit about what's special about having a young adult or youth and young adult going into the system from the Mass General Hospital for Children and into the adult hospital at Mass General. All right. So healthcare transitions versus transfer. Transfer from a medical's perspective is just transferring the care from one doctor to another. Wish it was as easy peasy as that. It could be if you have a kind of a savvy, if you're savvy yourself at navigating through the medical system, you have a savvy, typical neurotypical child that's going from a pediatric practice to an adult practice. It could be as easy as just getting a name and access, or even if you're at Mass General where the medical record is the same, it could just be easy as switching offices. Healthcare transitions, it's not a single event. It's a multifaceted process that addresses the psychosocial, educational, and vocational needs of adolescents as they move from a child-oriented care to adult-oriented care. And just the overall transition of preparing your young adult to navigate the model of adult care world. So just wanted to highlight some systemic differences between pediatric and adult care. As you guys know, and it's been complicated by the COVID pandemic, navigating the medical care in general and getting an appointment, getting refills can be very, very, very complex, even for an adult. My age 40s husband has sometimes struggles with this, and it ends up in my lap as well. So there's some system characteristics that are different. And this is actually, I want to kind of just highlight the God Transitions website. It's kind of trying to be the benchmark, kind of the gold standard about how we transition pediatric to adult care. I got to tell you, even in a place that we dual train physicians in internal medicine and pediatrics, we have multidisciplinary assistants. It's really challenging to do well. And the medical system has so many barriers, even on a good day, that sometimes it can be a little bit challenging. So just to highlight some of the systemic differences, the people in God Transitions took pediatricians, internal medicine specialists, parents, and they kind of brought it together to kind of really think about how best to transition care. Because especially if you have the more chronic medical problems, the more special needs, the more scaffolding and support that you need, it can be helpful to kind of guide that transition. So some of the systemic differences: orientation to care. In a pediatric practice, we are really focused on growth and development, versus in an adult practice, it's usually maintenance of well-being and aging. Although there's some transitions throughout the decades as an adult, really growth and development in terms of support is not as focused upon in adult care. In the practice approach, in between pediatric and adult care, family-centered and shared decision-making with parents. So parents are a very key portion of working with pediatric populations, explaining it to parents, supporting the child. So there's very much a family-centered kind of feel. In the adult world, it's very patient-centered, the shared decision-making with the young adult. So the focus is the patient. And then the patient can have a number of shared decision-making supports, but putting that highlight on the actual patient is making that decision. In the primary care practice, the patient population in pediatrics, majority do not have chronic conditions. So it's wonderful. We look at their health maintenance needs, their vaccinations, their development needs, take care of some of the things along the way, but majority of patients do not have chronic conditions. In the adult world, majority of patients have chronic conditions that we're tracking, we're touching base on, may need refills of medications, specialist referrals. So many of those things need to be managed and need to help empower the patient to help manage those. Specialty clinic and affiliation and locations. Most pediatric specialty clinics are located in the children's hospitals, which is uniquely located together. So there's a lot of collaboration because everybody's just down the hall. In most adult specialty practices, they can be in some private office-based settings. Thankfully, in Mass General, they're very located very close by. Multidisciplinary staffing. In many pediatric specialty clinics, they have their own social workers, case managers, a lot of different ancillary staff to help some of those specific disease processes. In some adult specialty clinics, there's not necessarily co-located with other specialists. We have some wonderful clinics that you can see 2 or 3 specialists at the same time in the pediatric setting, but in the adult setting, sometimes these are separated and not all in one place. Availability of care coordination, very prominent in pediatrics, but also getting more prominent in adults. So depending on what kind of specialty clinic or what kind of disease process there's additional supports for, we have integrative case management for different populations as well. So that's becoming a little bit easier to have people help with that. Length of the appointment, pediatrics, they do get a little bit of a longer time versus adult. It always seems rushed. You never get enough time with your physician, it seems. So a little bit shorter time. Ideally, in a pediatric setting, as your child grows into kind of the teenage years, your pediatric or adolescent provider will give part of the time alone with the provider, just so you can have some private discussions and have any personal questions. And that really does help kind of get them ready for in the adult world, where legally required for confidentiality over age 18, unless the young adult gives permission for others to be present. So hopefully we're preparing the young adult for that transition. Patient as self-advocate. There's during the pediatric time, there's less of that role, and as they age, they're giving a little bit more support in terms of presence. There's parent support presence during that visit, and they're usually allowed, as they get into their teenage years, a little bit more of a space for self-advocacy. But as an adult, this self-advocacy is essential. Patient role in making appointments and medication refills during the pediatric time. Parent generally handles this, but as adult, offices usually go directly to the patient. And so figuring out the best way for your youth or young adult to kind of start to assume some of those processes if they can. Adherence to care. So in pediatrics, we offer far more reminders and workarounds. Provider actually, if there's non-adherence or some issues, provider has a legal option of contacting protective services if necessary. As an adult, expectation of adherence, and it's a very patient self-generated. It's up to them to follow treatment and medication recommendations. The provider has no legal obligations. Can this be really tricky with really complex pediatric patients as they go further? They have, many pediatric patients, young adults can sometimes have limited insight, a prolonged kind of adolescence attitude towards their healthcare. And so making sure that there are proper supports as they transition to the adult world. Medication dosage is in pediatrics usually depends on weight versus adults. It's usually commonly one dose, but occasionally related to weight. So there's some, if your child or your youth or young adult happens to be underweight or overweight, there's some differences in medication that we need to look out for. Use of pain medications, they may have a longer trusted relationship with their specialist or their primary care doctor that understands a little bit their pain medications. And so liberal availability versus opioid contracts differ in the adult and pediatric world. And time in the care system. Usually in a pediatric world, we only get them at 18, 20, 22 years. As an adult, we can average relationships up to 50 years. So a little bit of differences between the two process. And as a parent or a caregiver, your role totally changes as your youth transitions in this process. When they are young, you are the provider of their care and the youth receives their care. As you get a little bit older, they get some abilities to provide some self-care. You become kind of the manager of that. Instead of brushing their teeth, you're actually reminding them to brush their teeth. And ideally, in an ideal world, right? In self-advocacy, they're the person that ends up being the manager of that particular self-care. And you become kind of the supervisor. And then they ask you your opinion. So you become the consultant to their use as they become the leader and the supervisor of their own care. So let's talk a little bit about healthcare transition timelines. So these are suggested about how you can start to prepare your youth or young adult for transition to navigating their own adult care. My apologies for the busy slides. I did try to kind of show that one side is for parent and caregivers, the other side is for youth and young adults, because this is really kind of a co-management. This is learning together and trying to enable them to do this on their own. So for parents and caregivers around age 12 or 13, you want to help your teen learn about their own health condition, be it asthma, be it headaches, be it eczema, certain things. You want to have them be able to understand their health condition, manage it, understand that they have medication and obviously allergies. You want to encourage your teen to ask questions about their own doctor about their own health, like what they can do. Sometimes this is tricky because at this age, we're just trying to get them to do the basics, right? So in terms of did you shower in the last 24 hours and just basic healthcare, basic self-care, that's a little bit challenging. But then empowering them to kind of own their own health conditions and help them do what it takes to prevent and explore their own medications. So ask your teen's doctor if and at what age they no longer care for young adults. And this very much varies. If they are seeing a opposite gender doctor, that kind of may come into play if they want a same gender doctor. If they're comfortable with that, most pediatricians' offices are very comfortable towards end of high school, college, but after that, depending on what the youth needs are. But knowing what your own pediatrician's health policy is to transitions can be helpful. This is the age too where confidentiality starts coming into play. And so knowing kind of what the office policy is for you to obtain healthcare. So for example, in Patient Gateway, if you're a user at MGH, there is confidentiality restrictions starting at age 13, and knowing what your needs are to make sure that you have Gateway access, especially if you're the one managing like their vaccinations, their school health forms and things like that, to make sure that's set up in the office. And that differs sometimes from office to office. For youth and young adults, again, you're starting to empowerment about their own health conditions, knowing that their medications, let them know when you're out so you can show them kind of like how it is, what is the refill process, and empowering them to kind of write their questions for their doctors before their doctor's appointment. And then again, when is it that the doctor, can they see their pediatrician until? Starting at age 14, 15, again, learning a little bit more about what your teen knows about their own health. And again, that's going to vary based on the complexity of their medical history. If you guys go to the Got Transitions website, there's actual like quizzes that they can take online that kind of tell them what are the next needs to do about their own health, and then kind of explore what is necessary to kind of advocate for their own health. And you can have those surveys as kind of discussions with your regular pediatrician. Kind of know what their own health insurance card is. There are some really neat apps if your teen is starting to use their phone, if they to kind of put their health contact information and things like that on their phone. Most teens, their phone is an extension of them. And so using kind of the medical information can be really useful, particularly if they have some complex disease processes. Help your teen learn more what they can do about their own health in case of emergency, who to contact, what their allergies are, what their medications are. Help your teen practice making a doctor's appointment and ordering refill prescriptions, prescription refills, either on the online, by phone, or through an app. And encourage your teen to see the doctor alone for part of the visit to gain independence in managing their own health care and their own health and answering questions. At 16 to 17, the kind of process continues. We encourage them to make their own doctor's appointments, ask their doctor questions they may have, and just remember to ask for medication refills if necessary. Ask the doctor to talk about the teen about what their privacy rights are when they turn 18. So what happens even in our office where we actually don't transition patients because we keep seeing them, at 18, our whole office, instead of turning toward the parent to ask permission, we actually have to go through the child. So we try to prepare everybody to say, okay, when you're 18, you need to let us know what you want your parent to be able to handle. Is it okay to talk to them? Or would you like, under what conditions would you like to be the first person to contact? Do we have your cell phone if you have a question? Work with your teen and your doctor to make and share a medical summary. And before your teen turns 18 and becomes a legal adult, figure out what they need help on making healthcare decisions. There's some definite resources on that website of Got Transitions, and this one's a complicated one. So if your patient, or if the patient and your child has some special needs, and that may be some neurocognitive issues, figuring out what level of legal guardianship, decision-making support is going to be necessary as the teen turns 18. Because at 18, in terms of getting parental access or getting parental permission or permission for any legal or medical procedures becomes a sticking point if it hasn't been thought out prior to 18. And talk with your teen about the age they want to transfer to a new doctor or adult care. Oops, I'm a little frozen here. Healthcare transition timeline, age 18 to 21. So at age 18, your child is a legal adult and legally responsible for their own care. It's kind of shuts off access unless the young adult agrees or certain legal forms have been completed. So especially if you have a youth or young adult with complex medical needs, having that turned on, making sure that pathway is clear at the age of 18 can be useful. If you need local resources, ask your pediatrician or the Family Voices chapter, and learn if additional changes at 18 that affect your young adult, health insurance, Social Security income. Encourage your young adult to ask their current doctor to help them find a new doctor, and make sure that the new doctor accepts your young adult's health insurance and help them learn if there's any charges at the visit. Finally, encouraging your young adult to keep a copy of their medical summary and always carry their health insurance information on them. Right. Finally, at age 22 to 25, encourage your young adult to get care from their adult doctor. Increasingly, particularly in the pandemic, there has been a significant kids in this age group, young adults in this age group, they use urgent care exquisitely. And if they have complex medical needs, right now, I feel like the ED is so overrun, and so that it's a good place to know that you're not going to have any maleffects of your current symptoms, but it's not a great place to figure out and manage your chronic health diseases. So encouraging to get an adult doctor and to continue to see that adult doctor. It does take time to learn them. Us as pediatricians, we get a wonderful 18 years, multiple times as a baby, to get to know their personalities, the nuances of the family structure, and how to support them. Adult doctors, the first time you meet somebody, we can take like maybe 15, 30 minutes in that visit to kind of get to know them, but they may not necessarily know all the supports that are needed. And so that's why a transition process is helpful. So you can kind of help piggyback off a ready medical home in your pediatric environment as you go into a new adult environment. And encourage your young adult to stay insured. A lot of young adults, they're off their parents' insurance by 26, which can cause disruptions in their healthcare. If they change their health insurance, encourage them to make sure that their doctor takes their insurance as well, and learn if there are any charges of the visit, because those are always surprising. So factors to consider for your youth or young adult in transition. So chronic diseases. So those are probably the most at risk in this, as they have some learning curve to learn about how to manage their own chronic diseases. If they have things that are nuanced to them, developing action plans with your current pediatrician, for example, asthma, if they're having what to do when they have an asthma exacerbation, and do those always need visits? Do they always need the emergency room visit? But if they have an if-then statement kind of action plan, they can be kind of ready and start to know what they need in advance. This can be transferred to their adult doctor, and then they can have these plans so they can help self-manage some of the non-emergent medical issues of their chronic diseases. Youth and young adults with special needs, especially if they have physical or neurocognitive disabilities, that's going to take a little bit of time to kind of set up. And so having a strong plan in place with your pediatrician to help identify an adult provider that would be supportive and a good fit, especially making sure that their actual physical structure and space is accessible to your child with special needs, and making sure that the particular clinic may have enough resources to support the different things that you have with the special needs young adult. Kind of discussing and deciding what decision-making support they have. How much input are they going to have? Are they able to, deal with their finances, deal with their insurance? Or are they on the more extreme end of neurocognitive disabilities where they may need guardianship, and that is a legal course? Or is there something in the middle that they need to do as they learn and gain time with some of these medical decision-making processes? Do they just need a power of attorney? Do they just need a healthcare proxy? There's many stops in between full independence and then full legal guardianship. Transitions of specialists, working with your PCP and your specialist to figure out which specialist to transition first. Is it better to transition the PCP first, keep the pediatric specialist, and then slowly transfer over the specialist? That's going to take a little bit of a roadmap and plan. And obviously it depends on who you're closest to, kind of the different supports, and how unique is the specialist to your child's needs. And finally, another population that definitely needs action plans and advanced planning is young adults with frequent hospitalizations. There is a large cultural barrier between the adult population in the adult main hospital and then the pediatric support in a pediatric hospital. That can be very, very challenging for some families to navigate, including who gets to stay bedside. I will tell you that we work somewhat on a systems level to see if we can advocate for those patients of special needs that may benefit from having a caregiver accessed by their side. So that is still in the works. Finally, transitioning Mass General Hospital children to Mass General. So the wonderful thing, it's an ideal setting for transitions, is there's a consolidated electronic chart and there's no necessary need to kind of transfer paper records over from one side to the other. There is a huge state of affairs with challenges with the availability of adult general providers in the state of Massachusetts. Current waiting lists can be months and months. And so my public service announcement is, if you are looking for an adult provider, start early, talk to your pediatrician to see if there are folks that they work with typically, or if they know somebody that would be a good match for you and your young adult. Working with your current provider for a seamless transition. So think ahead of time. You don't want to talk about this in your last visit. There's additional resources that they have through Karma, but this should be kind of a long process and not be, oh, by the way, we're going to college next month. They have, 4 or 5 specialists we need to transfer. There should be some graduation, some program, some kind of transition over to the adult hospital. There are efforts on the system level to provide pathways from pediatric to adult providers. So there's some seamless ones. For example, at MGH Revere, we both have a pediatric department and an adult department, with also an overlap of providers that we have 7 providers that function in the double specialty. And so obviously with the children that go from Revere Pediatrics, will be able to find an adult provider in the same location. Same thing with Chelsea. So they're trying to look for natural pathways in the MGH system that will kind of guarantee your child a spot at an adult clinic. There's care coordination. So if your child is qualifies for an integrative case manager, there are pathways to transfer those patients over to adult providers as well with integrative case managers. So check with your local provider if that is a special case that you fall under. And then I will let you guys know that there are pilot programs. Some of the med peds providers like myself, we are looking into pilot programs of consult services. There are sometimes we need multidisciplinary planning to help some of our children who are most highest at risk when the transition occurs. Perfect. So I also just wanted to go over a little bit of resources and references. Most of my information is gone from this website, gottransitions.org. Here you'll find a lot of interactive handbook and tools for the Family Center for all the different types of transitions that you're looking for. If you're going from a pediatric provider to an adult provider, what would you need? If you're going from like a family practitioner or a med peds provider and you're not actually changing systems, but how do we get our youth ready for that as well? There are a tab for actual patients for your young adults to kind of, and they're written in kind of plainer language. There's some parent handbooks about navigating this transition as well. In addition, there are benchmarks for providers and some additional support for providers to help youth with special needs transition. Perfect. I see we have some questions in the chat, so I'm glad I left a little bit time up for questions.
Sure. I can read the questions for everyone, and then you can answer them. Well, thank you so much. This is a very important topic, and you have lots of great information. Our first question is, what factors do you believe contribute to better transition readiness? Literature or research doesn't really point to anything other than gender or age.
That one's a tricky one. I can tell you nationally where we're at with that. The factors that contribute, I can tell you what the research says that patients greater than 400% above the poverty line transition well. People with involved pediatric providers or less than 3 specialists can transition very well. It is really challenging. I think there's a lot of social barriers and social determinants of health that make the medical system challenging for the everyday person. I think for folks that have pediatric or caregivers that have youth with special needs, it is very, very challenging. You finally are just trying to get through the day with some of these sets of issues, complications, medical issues, and just the everyday and complexity of being a young adult these days. I think it's incredibly challenging. I think support and just knowing what is out there. So I think some of these readiness surveys, having these discussions early, that's why, at 12 or 13, nobody wants to think about changing their pediatric provider. They are clinging to the one person that they've known for 12 years who maybe gets their space. But at the same time, classically, as parents of kids with special needs, we have a hard time letting go of it because that just enters some chaos. So having support, talking regularly about what are the baby steps I can take. Like maybe they don't know all of their medications because I can't pronounce half the medications, but maybe the ones that are the most important, like which is the red inhaler, which is the most important inhaler, those baby steps, and working with your pediatrician to help them get to know some of those things would be useful. Yeah, gender, age, all of those things. But I think in terms of the better readiness is start at any time to talk to your child about, you know, who their doctor is, what is their medical problem. And it also depends on severity, obviously.
Okay. Okay. Our next question is, how would a family with a child who has complex or special needs go about finding a PCP when they reach the adult care stage?
Yeah, that's I think the other question of like finding an adult PCP in the state of Massachusetts, particularly the Boston area, is a really, really challenging one. There are some incredible providers. I will put a plug in for people who do med peds. There are, if your child has lots of medical needs, people who are double trained, and there's a good amount of providers out there in the Boston area. We live for this kind of stuff. So we live for the pediatric providers, the pediatric diseases that like progress into adulthood. So MGH Revere, MGH Back Bay, MGH Everett are those MGH places that have the dual providers, and they all see the types of the same types of families that I'm saying. Some of those, but it is very, very, very challenging. If the families with children with disabilities, having your pediatrician reach out to people that they know, and because it can, you end up finding a different fit, and it's definitely a progress, right? So you meet somebody, you're like, oh my God, that's not my pediatrician, but you've had so much time to grow with that pediatrician. It's a little unfair to the adult provider. The adult provider, I don't know if you guys have seen been in adult medicine, it's a little business oriented. We talk about just the facts and things like that versus pediatricians were like, oh my God, I love your sweater, right? How are you doing today? We're so excited that you made it to school. And so finding the fit of that. So asking your pediatrician who may think that might be useful. Again, we have a nice small amount of people here. It is very, very complex. And that one of the pilot programs we are looking for is a consult service. So because not only is the consult service trying to help prepare families and looking at their individual needs, but we're also trying to train providers into what does a good transitions look like. So if we can help them, if there's documents out there that what a good transition looks like with action plans that are succinct, that are not 32 pages, that's somebody that you can, an action plan or a medical summary you can take to an ER where they can say, okay, my special needs child, this is what they look like when they're ill. These are the things that they look at, and help them do that. Here are the paperwork that they need for all of their incontinence supplies, right? And these are the times that we need them. If we can provide those good resources, it becomes less overwhelming as an adult provider to take on some of these challenges. I do not believe that all med-peds people should have the burden of taking care, but I do think that as med-peds people in a big environment, we should be able to teach pediatricians what like a good transition looks like, and we should be able to teach adult providers what a wonderful transition of care looks like, so it won't disrupt the life of a young adult with special needs or family.
Sure. Okay. Our next question is there a good timeline for how many more times someone should see a doctor to make a smoother transition?
That is tricky. The system, it doesn't always allow go back and forth and go back and forth. You technically can, but it becomes confusing in the system, and then practices sometimes get in the way. So you'll say your PCP is your pediatrician, but then they'll transfer you to your adult, and then everything will go to the adult provider, yet the adult provider hasn't been properly primed to take care of everything. And the pediatrician goes, oh yeah, well, we transferred them. So it's a very challenging time for that portion of it. I would test out to see that portion of it. You don't necessarily have to leave your pediatrician yet. Even if it says it on your insurance card, it'll still go through medically. But it's a good timeline how to see a doctor. I think it's more about preparing you than preparing the doctor. I mean, theoretically, any medical physician should be able to take care of you and your child. I have some complex adults. I have complex kids. It just takes a little bit of while, but it's the idea of like, what are the most important things, and transitioning in a time that's good for your family, and that you have all the supports that you need. So everything is not an emergency during that first visit.
Okay, perfect. Our next question is, how do you deal with potential resistance from doctors who may have trouble letting patients transition?
Yeah. As a person who has been in the system for 15 years trying to do transitions, there is a lot of resistance. People get very attached and, for very great reasons. And so broadening that, so we're not necessarily letting go of that portion of it, but the idea of adding. So there's the idea that your pediatrician will become a consultant to you, and then they can even bill as a consultant. So the idea of what you need from that particular provider, that CF provider, versus what you would need from otherwise. And you can use a primary care to kind of see if you can help navigate that. But, we love our patients. It's very, very hard to let go. And you'll see some pediatric providers hang on to their kids 30, 40 years, but they won't necessarily, the challenging thing is they may not be able to see all the different things that happen to young adults with these chronic diseases as they get through. They'll have that lens of that specialty, but at some time at 40, we're going to have to talk about like cardiac prevention in addition to some of those things, because many things happen in tandem.
Okay. Are there I think I'll generalize this next question. What are some ways that Mass General specifically is helping prepare children for the transition to adult care, because everything at Mass General is under one roof?
So the wonderful thing is pre-COVID, we all got together and there was a multidisciplinary team. And so we're calling ourselves the PATS Consult Service. So it's the Pediatric to Adult Transitions Consultative Service. So it was myself and two adult hospitalists realized that how we do transitions isn't ideal. And it's not just about the doctors, but it's some about the multidisciplinary. The nurses in the pediatric floor had, wonderful, heartwarming experiences, which they wanted to see them have the same level of conscious care. And so there were warm handoffs from the pediatric bedside to the adult bedside. And so the pharmacists were very involved in some of the pediatric care. And so they wanted to be involved, the physical therapists and the ancillary staff. So we all got together and we were meeting monthly to kind of create this consultative service that would provide medical summaries over time. And we were using kind of the acuity of the inpatient, the time of the inpatient to help start some of these conversations off. It's a cultural change for many providers, patients, and things like that. When they're in an inpatient setting, you're not looking to switch out of a place to an unknown place. You're not looking to go bigger. You're looking to go to people who know you, who know your child well. You're looking for names and faces to make and so there's a lot of resistance that we had, but it's still very, very necessary, because unfortunately it's going to happen. Thankfully, if your child is surviving, your child is growing, it is unfortunately a necessary step. And so how we can take steps to make that a little bit more easy with familiar faces that you've seen. So some of the small wins is getting Child Life to go to the adult ICU, to get, art therapy to some of these places, to get, your providers, your nurses to come check on you, and actually made such a huge difference to do that. In the outpatient, there are incredible resources to help prepare you. It's just everybody's in a really, really different place. And to have something standardized, it can be very overwhelming. There are some families with special needs who are like, perfect at navigating the medical system. They are old hats at it. But there are some families that, especially with medically fragile folks, where they don't know what's happening in the next 2 to 3 months. They barely know what's happening the next week. My medically fragile child never had the same day twice, right? So it's really hard to plan for those things, and especially when you're not at a comfortable space that you're not going to want to lose one particular provider or not. So it is very individualized, and that's why talking with your pediatrician, complex care service, how we do that. And there's a number of level of supports on different, it's just tapping into that and finding a time with your providers and your current team to do that.
Okay, perfect. Okay, our next question is, how would families start the conversation about transitioning with their own children? And I know you mentioned around age 12 to 13, but how would that conversation start with the child?
So basically, I think just keeping it similar as you were doing transitions for like high school, you know, as you get older, you have more responsibilities, right? And that includes taking care of your body, right? And so sometimes I have a 12-year-old or 11-year-old. I'm like, okay, you know, let's talk a little bit about your sensitive skin. This is the name of this is what we call it. And these are the medicines that we use to do it. And so kind of getting that in kind of a like, we're about to boot you from your practice, let's get this ready. But like the idea of transitions is trying to empowering your child to start to know about their own body and advocate for their own healthcare. And so, you know, even though it's incredibly awkward, and I have a lot of like 12 and 13-year-olds that are not ready to have that space and time with the pediatrician, I reserve at least 5 minutes to be like, okay, I'm going to have you exit. If there's anything else you want me to talk about, please let me know. And I take the time to talk to the child a little bit about, okay, this is your body. You may have some questions about normalcy, and just encourage them to ask their own questions for that portion of it. So it's baby steps each year. It also depends. Sometimes, you know, the parent is just getting the hang of navigating the medical system and then managing their own particular complex process, right? So it may not be time to challenge the child, but knowing, like giving them something to do, and that's the progress that can be made. The wonderful thing is, again, on that Got Transitions website, it kind of tells, it's some of those surveys help tell the physician where the child is at or where the patient and families are at, so that the patient and families can tailor, the physician can tailor how they present things to where they're at, not necessarily expecting to be like, well, you're 17, you should manage your own medications. Even a lot of my 20-year-olds and 30-year-olds do not know the name of their birth control. They don't. Not even that, not even a sounds like, they just know they're on birth control. So it is not uncommon even for adults.
Okay. That's a good segue into the next question. What should families do if children are hesitant to take on their own care at any stage, if there's a hesitancy from the child?
I think I've seen a really great example. I have a child who has transitioned and unfortunately had a kind of a larger thing that we discovered at the age of 18. And they keep on going at it as kind of a family decision. And that helps clarify things for the adult providers as well that they encounter, that this is a family decision. And it does, I honestly does, it does take a little bit longer to empower them. And so I think that's where the resistance on the medical side is. But the idea of like, here's what I would suggest, right? And this is going to be a lot of puppeting throughout their young adulthood. This is what I suggest as a family decision. This is up to you, but this is kind of things that I would consider. Of course, it is very hesitant. Many of my adults are very hesitant on making a decision because what the providers say can be very overwhelming. And so the idea of the non-pressure, we're going to decide this to the family. Sometimes there's really no decision to be made, but you have to agree because of what the medical acuity is. So for example, they need a surgery. You know, really bad things happen if they need a surgery, if they don't get that surgery. The language is consent, right? But the actuality is it's an emergent situation and we need to get them on board and help them understand that and provide them that support in that place. So I can understand it's very reticent, but then giving them the baby steps and see what happens if you do let them make that decision. What if you don't make that decision? What happens? And help and giving them some practice so the first medical decision they make is not the life-threatening one.
Okay, perfect. Let me see. And our next question is, what should children do to prepare for their first adult care appointment when they've reached that, 18 to 22 age and it's their first official appointment without the parents there?
Write things down. That's the number one. Write medical concerns down. If there's anything, there's a lot of my young adults who come to me for the first time have no idea what their family history is. They sometimes, I recently had a 25-year-old with some history of complex diseases. And she kept on saying, it's in my chart, it's in my chart, but she received all her care at Children's. I didn't initially have access to her chart, but she was very used to having all of her providers know her. Now, she was able to give me consent to go get said information. She was able to let me know that I needed to contact her family. I don't see all adult providers doing the background legwork, but I was very impressed that she came to her appointment. She had a list of things that she needed to have. She needed a note for things. So we're starting off that process, but it will take a couple of visits for us to kind of get to know how best to support some of her decision making. But it did take a couple of phone calls with, okay, can I talk to your parent? All right, the parent wanted to talk to me separately. And so all of these occurred after the visits, but it is difficult to sometimes know how to proceed, especially since we don't always get the information ahead of time. So there's sometimes a warm pass off. And for my complex kids that are graduating from pediatric patients, it's wonderful to have that head start so they don't have to start fresh. But it's nice when they write everything down that they want, what the top things they want the doctor to do, because I guarantee they're going to get there. They're going to get their vitals done and forget everything that you were supposed to do when you get there. So.
Excellent. That's another question for our 18 to 22-ish group. What are some ways that at MGHfC that we encourage that population to come in if someone, notices that the transition is, maybe that patient is not coming in for checkups or important reminders or things like that?
That is a aspirational type of thing, is the follow-up. I even in a pediatric practice where I'm like, I haven't seen this patient before. They used to be here. And my 25-year-olds will definitely no show. Probably in my population, I'll get, if you were 25 in my practice, I've never seen you before. Anywhere in your 20s, I have a 20 to 40% chance that you will no show your first visit. And it just doesn't show up on the radar, unfortunately. The thing is, and so we can call ahead. I mean, we have mechanisms where we call ahead of time. I do outreach if I see somebody has no showed and say, hey, let's try this again and try to reschedule and see if they have that access. So there is that portion of it where most of the offices will give them another additional chance to do that portion of it, but that is a chronic issue all through adult providers in general. There is at some point, if they don't show up multiple times, the adult provider will probably assume that they're not interested. Unfortunately, that's a dangerous space in our high risk young adults. So I do try to make the effort, but it is challenging to see who is going to need. Sometimes it's not very obvious from their chart who needs that extra outreach and not.
Okay, great. Our next question is, how do you balance teaching teenagers with a chronic condition that the condition should not define their life, but at the same time, they should understand the importance of their follow-up care?
I think that's a really tricky one. And a wonderful reflection to think about. I do think that your children are far more than the list of diseases that we constantly boil down in a medical setting. And so the idea, even phrasing as in, patients with diabetes as opposed to diabetic patients, can be very empowering, that they are multifaceted individuals who may have chronic diseases and a range of abilities. We all have ranges of disabilities, right? And so seeing past that into complex, incredible human beings that, we all need preventative care and we all need certain levels of self-care to get our bodies to work the way that we do. So classifying that as it's like similar to brushing your teeth. You just have to go see the doctor, similar to doing these things, keeping ahead of those things, putting gas in the car, getting your car checked out, right? It's similar to those things. Granted, they don't always have that line of thought process yet, but it's just kind of doing that. This is normal, everyday adult type of things. We all have to do it. Some of these things are a gift. Some of these things are challenges, but you definitely have the capacity to do this.
Great. Let me check the chat box one more time. I don't think I see any other questions, but if someone does have other questions, please be sure to send them over in the next minute or so.
There is another question that I saw. If I met, do you collaborate with Bridges
Yes.
Transitions over at
Yep.
the Brigham? Yes, there's a finite number of people interested in transitions in the Boston area. We do collaborate with them in terms of the process and things like that. In terms of Boston, so they too have access issues with adult providers. There is also, depending on your child's specialty needs, sometimes the coordination about, is there an adult level provider that specializes in a unique childhood disease process at an adult level, that can sometimes be challenging. And so finding equal people does require a little bit of networking in that. So definitely, yes, so we do, they sometimes look to us, we sometimes look to them if we're trying to find specific needs for those patients. There was also a question in the chat about how the consult services can be accessed. Again, these are pilot phases. I will say to the 13 attendees out there, I will put my email in the chat. If you are interested in some kind of service that, again, this is opening, and during COVID, our services did take a dip. We used to be able to provide them, but we can open up that discussion, or it can help you work with your pediatric provider. So I'll put my email in the chat if that is. There, I just ask that there is no emergency, that transition should not be an emergency, but it's a plan type of thing. And so if you are contacting me, I'm happy to think and plan those types of things and see what resources that you may point to. But again, it shouldn't be an emergency service, because that's what your pediatrician is there for, just for safety reasons.
Great, thank you. Okay, I haven't seen any other questions come in, so I think we are good.
Thank you so much for your time, Dr. Galvez. Thank you so much, everyone, for joining us today. As I had mentioned, this session is being recorded, so if you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.